Welcome to Season 3 of MIGS Unplugged. My name is Ike Ahmed from the University of Toronto. With me I have Valentina Lozano, also known as Gator Surgeon on Instagram, and we have Jeb Ong, also known as Jeb Ong. Today we want to talk about the iStent Inject. The iStent Inject has been one of the most popular MIGS devices now used in the States and around the world. There's of course some important learning curves in managing some of the potential implantation issues. Valentina, tell us a little bit more about how your basic implantation technique is for the iStent Inject.
Yeah, sure. So the iStent Inject is a little bit different than the iStent first generation. You have two devices inside of this guide wire covered by a protective sheath. I think a few points here is the way you grab the iStent. We typically hold it as a pencil. So whenever you go, before going into the eye, I would just use that slider to get that protective sheath out. Sometimes it gets stuck, so just try it a couple of times. Once you feel comfortable, go inside of the eye with that protective sheath. Once in there, you can go ahead and release it. So now you can see the guide wire. And then before you go to the angle, just so you don't make any mess there, just change your index finger from that sliding to that push button. That way you're ready to go. Since you're injecting two iStents, I feel like you have to go at least 2 to 3 clock hours. So in the first one, if you're right-handed, try to go to the left as much as you can, because the other position, you really have to make a different grab, and it gets harder the more you try to go to the right. So in this case, whenever you see that guide wire, go to the TM, go in the middle of the TM, dimple a little bit, but right before you see some striae, that's when you should go ahead and push. And once you push, you need to release slowly, so just pull back slowly, but don't release your pushing. So just stay with that, release as much as you can, pull back, and then you release your finger. Then you go ahead and try it on the other side. Again, 2 to 3 clock hours. Sometimes you can't do that, so try to focus on that place where you see a lot of blood reflux, that tells you that you are really in a good spot where the aqueous veins are located. And again, dimple a little bit before you see the stria, push, and then gently pull back, making sure that the guide wire stays in the middle. If it touches the cannula, then it's really hard for that iStent to be placed in the correct place. Sometimes it can get stuck, and that gets tricky.
I think it's a great pros, and I think you're mentioning about trocar bias, where the trocar is maybe biased or pulled over to one side of the cannula, right, which will misfire the implant. And I think the dimpling down is probably one of the most critical parts, but it's hard to really describe. But I like the way you're describing it, where before the stria is seen, that's enough pressure. Mm-hmm. Sometimes what I'll do is I'll push hard enough where I see some stria, and then I'll back up a bit so the stria goes, and then I think that's kind of a good place. And I kind of talk about the V versus the U. I mean, if you see a V pattern where the whole indentation of the canal is like a V pattern, right, for Valentina, might be too much. Sometimes you are. And as opposed to a U where it's more of a gentle curve, So there's some pearls on that. Now, Jeb, I mean, the Inject is really an incredible, feat of engineering. Slick device, as you know, two pushes and you have the implants in. But the implant may be under-implanted or over-implanted. Yeah. And I know for surgeons, even seasoned surgeons sometimes get into difficulty where the implant is under-implanted, meaning it's in the AC too far, or too deep, where it's too deep into the canal or into the spur. Can you share some pearls in terms of managing those conditions where it's under or over-implanted?
Yeah, so let's first tackle under-implantation. I think just to echo something that Valentina was saying, which I think can lead to under-implantation, is this issue of releasing the button before your iStent is actually fully outside of the guide wire. This is why we typically say keep it pushed until you're completely free and then you come off. Because we do think that that release might cause a little bit of movement, you might get a bit more trocar bias, it might actually get stuck, and it ends up kind of pulling your iStent a little bit out as well, right? So I think that's one reason you might get under-implantation. Now, if you already are under-implanted, some of the things that you can do is you can actually put back the protective sheath. You can try to use the tip to kind of get right in the middle of that iStent and push in a little bit. Sometimes that can be difficult, especially with the newer generations. I've noticed the protective sheath tends to be a bit more blunt before it used to be a bit sharper. So I think the other thing you can do is pretty much just try to reload it, put it back in the guide wire and actually reload your iStent, right? Because you do have a few shots with that. Now, the whole issue of over-implantation, that can also be pretty tricky, right? And that's the part where how much indentation are you doing, which, that's a bit difficult. That does come with experience to a certain extent. So one thing you can do is you can grab iris forceps and you can actually push on the sides of the iStent. You don't touch the iStent, by just pushing around it, you'll often see that the iStent kind of pops back out a little bit, right? And that, again, there is some experience involved because sometimes you push a little too much, it might actually come out and now you're under-implanted, right? So those are some key things that I find are pretty helpful to kind of fix those issues.
I think that's great. Those are great pros. I think having a micro forcep is helpful in those situations. I think we got 4 shots that we can use. So if we have to reload, I think it's not the end of the world. I think what thing's important, of course, if we reload, is to not then necessarily go full dimple in, because the implant is now toward the end of the cannula, not back. So I think just more of a flush works on that. And I will say, I think that viscoelastic is kind of a variable, right? If the eye is really filled with viscoelastic and the pressure is really high, you dimple a little less. If the pressure is a bit low, you may have to push a bit more. That's where the stria, comes in there. Any other challenges that you've seen? What about blood reflux? Sometimes people get a little bit worried about blood reflux, and you got blood coming, and what do? I mean, blood is normal to see from the canal.
Yes.
But you expect that sometimes it's more than you want.
Right, and it gets tricky because if you do one and then you get that blood reflux, it can kind of, you can't see the other side, so it can really obscure your view, so that you start getting worried. So once you do one and you really can see, just go and grab more OVD, just go over there and make sure that you're inserting it so that, let's say you do the left one, put some OVD on the right so that you push all the heme towards the left. That way you still have that right view much more clear.
Great. Any other challenges you want to share or pearls as far as getting out of situations with the Inject?
Yeah, so I think for a lot of right-handed surgeons, really that second iStent that's a bit more to the right is very difficult. That's where oftentimes we actually change the grip that we're using to hold the iStent, right? There are a lot of times you typically refer to it as like a cigar grip. So you're actually holding the iStent kind of like this, and that way you can really go all the way 2 to 3 clock hours away from your first one. That's a key thing that you don't often see in videos, because the video kind of just shows you what's inside the eye. And a lot of this thought process that has to happen when you're kind of preparing for it and thinking about how you're going to get that far away from your first one, right? So I think the grip with your the way you're holding that iStent is very important as well.
Well, thank you both for sharing pearls with iStent Inject. The Inject is kind of a mainstay in MIGS and a device I think that can be learned. It's good to know some of the pearls and managing under and over implantation as well. So thank you both for sharing your thoughts. Thank you for listening in on iStent Inject. I hope we've been able to share some important pearls with the routine technique as well as managing under and over implantation. Stay tuned for more episodes of MIGS Unplugged.